Okay, guys, so this is Dr. Mobeen. We are talking about the arrhythmias and evaluation of the arrhythmias. This lecture is part of the interpretation of the EKG. The lecture today is the next step. In this step, we are going to be talking about the sinus arrhythmias. So I have no disclosures. Objective of this particular lecture is number one, to talk about the prerequisites. So let's talk about them right now. For this particular lecture, I have done a lots of pathophysiology lectures with the EKG changes and why the changes occur. So if you go in the cardiovascular system and in the EKG module of the cardiovascular system on our site, you will see arrhythmia lectures. Please make sure that you have gone through those lectures, because over there I have discussed the pathophysiology and linking it to the EKG. Secondly, one more prerequisite which I would recommend is that I have discussed the EKG paper, the width of the paper, the height of the paper, what goes on x-axis, how to measure the heart rate, how to measure the current and voltage, and what is the reason behind that. So I have done that in detail. I do not want to do that here. This topic particularly I want to keep focused on the EKG strips and how to measure the or how to identify the arrhythmias. So now you know what are the prerequisites. What are we going to do in this series of lectures? So again, this series of lecture is part of the EKG interpretation series. How to detect cardiac arrhythmias. That is very important. How do you see an EKG and say, all right, I understand that there is an arrhythmia going on? What are the type of arrhythmias? There are 5 types of basic arrhythmias, so you should be able to know how to identify them. Then how to differentiate between these arrhythmias. How do you say that this is the sinus arrhythmia versus this is the junction arrhythmia, and so on. Then what is a sinus arrhythmia? Today's lecture is about the sinus arrhythmia. Then the mechanism of ectopic rhythm, how to identify the ectopic rhythm, how to differentiate between the supraventricular arrhythmia and ventricular arrhythmias. So these are the topics that we will cover. Let's start. A few definitions that we should keep in our mind when we are discussing the arrhythmias. First of all is the sinus rhythm. So the sinus rhythm is that we have the SA node that has automaticity, and it produces the heartbeat or electrical current for the heartbeat every so often, about 0.8 of every second. So that rhythm that is generated by the SA node discharge is called sinus rhythm. This is the normal EKG rhythm generated by the SA node. What is dysarrhythmia or arrhythmia? They are the same thing. Correct will be dysarrhythmia. We can call them arrhythmia. That is a traditional way of speaking about them. Arrhythmias are any abnormality in the rate, regularity, site of origin of the impulse, cardiac impulse, or any problem with the conduction. All of these collectively are called arrhythmia. So arrhythmia doesn't just mean that you go to the, you say that the heart rate is up, below, or low or high. Instead, any problem with the rate, regularity, with the origin and conduction of the rhythm. Now, please keep in mind that in all of us, healthy individuals, it is actually possible that there are aberrant beats or ectopic beats or occasional arrhythmias which are short-lived, which may be 1 beat or 2 beats, which may be short-lived pauses. Even a pause is an arrhythmia. An extra beat or extra systole is arrhythmia. A missing beat is also arrhythmia. And it happens in individuals. Sometimes we have this expression that I heard this news and I skipped a beat. It happens. And you don't have to go about fixing that and figuring it out that what to do about it. It just happens. So keep that in mind, that sometimes arrhythmias happen in normal individuals without any issues, and you don't need to go and fix them. Then there are arrhythmias that are also normal. For example, athletes Good athletes work out so much that their hearts have become so strong that they pump out a lot of needed blood with one beat. So they don't need a lot of beats per minute. Their lower 40, 50 beats per minute, 60 beats per minute can actually meet their body's needs when they are at rest. So in that case, that is an arrhythmia, but that is okay. Similarly, if you and I start exercising right now, our rhythm heart rate is going to go up. That is normal arrhythmia. It is not really arrhythmia. It is tachycardia, and it is normal as well. So now what are the manifestations of the arrhythmia? Why do we care about arrhythmia? Look, as I just said, frequently arrhythmias are normal. It is okay. It happened, went away, no issues. But then in certain pathological conditions, it is possible that arrhythmia can cause a problem. So what are the problems? Let's go from less severe problem to more severe problems. Palpitations are the most common thing. Palpitation is what? It is patients' awareness of their own heartbeat. So, and I think we all have experienced palpitations. Then symptoms of the reduced cardiac output. When there is a problem with the rhythm and heart is not able to sufficiently pump out the blood and the cardiac output drops, oxygenation drops, flow of the blood drops to the tissues, then the symptoms of reduced cardiac output, for example, disorientation, for example, confusion, for example, fainting, all that can happen as well. Then symptoms of angina pectoris. Imagine the heart starts beating fast, and it is beating so fast that its own need for oxygen has increased. And heart provides itself with the oxygen during the diastole. And as the heart rate goes very fast, the duration of diastole reduces. Heart has less time to provide energy to itself. And if the beat keep going up, if the heart rate continues to go up, that can cause angina pectoris or ischemic disease. So that is a problem when somebody's heart rate is going up and you cannot control it. You don't just have to think that, hey man, I need to control the heart rate. The danger there is that the heart can develop ischemic issues because of extra need for its own work. And precipitation of the acute congestive heart failure. It is possible that somebody who had a problem already with the arteries and arteries of the heart, and there is a block somewhere, there is an atherosclerotic plaque somewhere, and all of a sudden the arrhythmia occurs or the heart rate becomes faster and the need is more, and actual congestive heart failure gets precipitated. That would be an acute congestive heart failure. And finally, the most aggravating situation will be when a patient actually develops sudden death and dies because his heart rate either just heart stopped or heart rate went up so much that finally it became just fibrillations and flutters. So takeaway from here is simple. There could be nothing with the arrhythmia, or there could be up to death. So, and everything in between. Now, what are the possible causes of arrhythmias? So please remember, this is a very famous mnemonic, his Debs. So what are the causes of arrhythmia? Hypoxia, ischemic or nutritional heart disease, sympathetic stimulation, overstimulation, bad news, good news, overexcitement, the fear, anxiety, that can cause arrhythmias. Drugs, of course, can cause arrhythmias. Electrolyte imbalances can cause arrhythmias. Bradycardia can result in arrhythmia. So somebody's heart, if it is beating slower, that can result in body asking for more nutrition, causing the sympathetic system and other systems trying to drive the heart, and then imbalances that are occurring in the heart's conduction can cause arrhythmia. Then the stretch of the cardiac tissue. This is very, very important, and I have discussed it in detail in our pathophys lectures, that sometimes when the heart has become dilated or heart has an injury around which the impulse travels, the time to travel becomes so long that it reaches back to the original point. Ideally, that point should be in refraction. Sometimes it has recovered because the impulse was slower, or the length of travel was longer, and the tissue has come out of refraction. It has become ready for another impulse, and this impulse comes and just re-enters that tissue, and then the arrhythmia will occur. Very important concept, and I've done that in detail. Now, rhythm strip. So how do we start identifying the arrhythmias? So one important thing in the modern EKGs is that there is a rhythm strip at the bottom that is lead 2. So lead 2 is this lead here. This is the most important lead because the pathway or the direction of the lead is the same direction as the conduction pathway of a normal heart's electrical current. So lead 2 has a, if you see in this particular EKG, the bottom is the lead 2, and that's a continuous strip that is called the rhythm strip. Normally there are 3-second markers as well, and you can see 2 markers that make it 6 seconds, and you count the R waves there and then multiply it with 6, and that would multiply it with 10, and that would give you the rhythm in a per 1 minute. Plus, looking at the rhythm strip can help you figure out if there are rhythm abnormalities. So how do you determine the heart rate? Again, I've done that in detail. Here very quickly, heart rate can be determined by counting the large boxes on x-axis horizontally between the 2 R waves. And there are 300 large boxes. One box size is 0.2 second, 300 large boxes in 1 minute. So what you do is you count the large boxes between the 2 R waves and you divide 300 by that number. For example, let's say that somebody comes to ICU. This patient has to be in the ICU. Somebody comes to ICU and they have, I don't know if they would be living, but anyways, let's say their heart rate is, there is R wave after 1 box. So you take 300 and divide by 1 box, that is 300 beats per minute, which is really a fatal heart rate. So anyways, if there are 2 boxes between the 2 R waves, then the 300 divided by 2 is 150 is their heart rate, and so on. So that is a quick way. Again, as I said, there is one more way, and that is look at the rhythm strip, look at the 6 second and count the R waves in 6 second, then multiply it with 10, which is the 10 6 seconds in a minute, and that gives you the heart rate in 1 minute. Now, can you calculate the heart rate in this EKG? So let me do that here with you. Look at the bottom, that is the strip, lead 2, rhythm strip, and I can see, so identify an R wave that falls on a boundary, and there are many R waves that are falling on the boundary, so hopefully you can find one. I'm going to take the first one and then count the number of boxes from one R wave to the next R wave. So here, 1, 2, 3, 4, 5, 6, 7 boxes. So about 7 boxes. If I go back here, 300 divided by 7 is about 42 beats per minute. So this person has a rhythm of 42 beats per minute. Now, what are the types of arrhythmias? Look, there are sinus arrhythmias that are because of the SA nodes problems, or simply said, the whole conduction system is normal, but rhythm has a problem. So such arrhythmia will be called sinus arrhythmia. Then there are ectopic rhythms where the SA node has stopped working, some other part of the heart has taken up the rhythm generation duties, and that is ectopic rhythm. Then is the re-entrant rhythm. Here the SA node is the one that generated the rhythm, but as I said before, the heart is either injured or heart is dilated, and the impulse just kept recirculating and re-entering. So that is the reentrant arrhythmia. I've done that in detail. I don't want to waste your time with pathophys here. Blocks, conduction blocks, are actually also arrhythmias. And then pre-excitation arrhythmia. What these are that there are accessory pathways, like in Wolff-Parkinson syndrome. There are accessory pathways from the conduction block. This is a congenital abnormality, and those pathways create extra circuits. And these circuits can cause impulses to travel in cycles and just cause arrhythmias, normally surgically corrected. Now, if these are significant. Now let's talk about the SA nodal arrhythmias. Notice I did not call them sinus arrhythmias because sinus rhythm or sinus dysrhythmia or sinus arrhythmia is also used for a term of change in rhythm with the respiration. That is also called sinus arrhythmia. So that's why I did not put here sinus arrhythmia. I called it SA nodal arrhythmias. Although the change in the rhythm with the respiration is correctly called respiratory sinus arrhythmia or RSA. Okay, so what are the sinus rhythms? So whenever somebody says sinus rhythm, what should go in your mind? In your mind, you should say, well, this means that the whole conduction system is okay, SA node is working okay, pathways are fine probably, and we are looking at the rhythm due to in the presence of a healthy normal system. So what is a normal rhythm? Normal rhythm is between 60 to 100 beats per minute generated by the SA node. Now what is bradycardia? Sinus bradycardia. So SA node is working. SA node is responsible for creating the impulses, but the impulses are below 60. That is the definition of sinus bradycardia. There can be bradycardia, which is not sinus, meaning the SA node is not working and some other part of the heart is working and the impulses are low. So please remember to call it sinus bradycardia. Similarly, what is sinus tachycardia? Simply any beats above 100 in the normal healthy sinus SA node and the beats coming from the SA node and the number of beats greater than 100 will be called sinus tachycardia. Again, this is not tachycardia, this is sinus tachycardia. Normal tachycardias are generally sinus tachycardia. The reason for that is that, let's say if the SA node for somehow got damaged, ventricles have taken on the responsibility or AV node has taken on the responsibility. These tissues cannot produce tachycardia. They normally are slower than the SA node. So somebody who is in tachycardic state will usually have the SA node working okay and overworking, overdriven. Then respiratory sinus arrhythmia, as I just said, that is the sinus arrhythmia as well, and that is when a person is inspiring and expiring or inhaling and exhaling, the medullary respiratory centers spill into the sympathetic system and parasympathetic centers, and they influence those centers. So when you are inhaling, the heart rate goes up, and when you are exhaling, the heart rate goes down. This is called sinus arrhythmia. Please do not try to identify sinus arrhythmia on a simple strip and say, I know this is sinus arrhythmia. Normally, sinus arrhythmias are identified when the EKG is superimposed on the breathing pattern. And then you can say, well, look, here is the inspiration, and with each inspiration, there is a little faster rhythm. And here is the expiration, and with expiration, there is a little slower rhythm. And it is that way again and again. Then you can say this is sinus arrhythmia. Now, sinus tachycardia. So let's look at these types, the arrhythmias at the SA node or due to SA node. So sinus tachycardia is SA node is intact, it is working, and it is causing increased heart rate. It can be totally normal. You start doing exercises right now, you start running around, jumping, and your heart rate would increase. That is sinus tachycardia, no problem. Don't try to fix it. However, in abnormal states as well, sinus tachycardia can occur. So what are those states? Congestive heart failure, where the body's need is lower and heart needs to pump higher, so it goes in tachycardia. Eventually it would fail by staying in a very high state of function, but sinus tachycardia can occur in the congestive heart failure. Lung disease, that is causing pushback on the heart, and heart has to then push out, and that not meeting the oxygen demand because lung is not working correctly for gaseous exchange. The load will go on the heart to go in tachycardic state so that it can pump more and more blood and circulate more blood with tiny amounts of oxygen to compensate for less oxygen and provide the tissue with its needs. Hyperthyroidism. An important thing here is that in elderlies, hyperthyroidism may be the only, the sinus tachycardia may be the only presentation of hyperthyroidism. The other things might not even show up. So keep an eye on thyroid levels. And then some more generic things: anxiety, fever, pain, anemia, malignancies, malignant hyperthermia, dehydration, mercury poisoning, sepsis, pulmonary embolism, stimulants like caffeine. I take a lot of coffee, and so I go into palpitations every once in a while. Then I know I need to cut down on the coffee. Electric shock, drug withdrawal, postural tachycardia syndromes, and so on. You know that there are 10 beats of the heart rate to increase with each degree of the fever. So these are known things. Now, do you go in and start fixing them? Not necessarily. It depends what is the underlying disease. So here, let's look at a sinus tachycardia example. Can you now can you find out the rate? So let's see. I'm going to look at the strip number 2, and I'm going to see where an R wave falls on a boundary. So here it is falling. So between the two R waves, the boxes, large boxes, are 2. So 300 divided by 2, 150. So this person has a rhythm or rate of 150 beats per minute. So of course that is sinus tachycardia. Why it is sinus? Everything else is normal. P waves are there, QRS waves are there, T waves are there, rhythm, the structure is normal. So SA node is there. The P wave's presence is telling you that the SA node is working, and it is present in every QRS complex, with every QRS complex. So this is a sinus rhythm, and it is sinus tachycardia. What is sinus bradycardia? It is the opposite, right? So any heart rate that is below 60 is, and normal sinus rhythm is present. That means P wave is present, QRS is present, T is present, SA node is working, heart is healthy, but we are in bradycardia. That will be the sinus bradycardia. Now, again, it can be normal. Athletes who work out, they at rest have a lower heart rate than compared to us people who are not athletes, and that is just because their hearts are strong. But this can be abnormal as well. For example, depressed automaticity. There are 3 basic reasons that the bradycardia can occur. Automaticity of the heart becomes depressed. That means SA node is working less. Conduction is blocked. SA node is working okay, but the conduction is not going through correctly. Or the SA node is there and is working, but because of the conduction block, some other part of the heart has taken up, creating the pacemaker activity, and that is the escape rhythm, which is usually slower. These are the 3 basic problems that can occur and that can cause bradycardia. So if you see all the reasons below, all these reasons are going to be able to go into 1 or 2 of the reasons above. So acute myocardial infarction, that would cause re-entry. Ischemic heart disease, vascular heart disease, valvular heart disease, they would damage heart in various ways, eventually either causing re-entries or dilating the heart, making it big, and then causing the heart to function incorrectly, conduction to be blocked, and the bradycardia to occur. Parasympathetic overdrive. So for tachycardia, sympathetic overdrive. For bradycardia, of course, the opposite thing is parasympathetic. So vagal tone, sudden surprises, sudden shock, vagal syncope is very common, where somebody hears a bad news and passes out. Similarly, surprise. Somebody jumps into a pool and the whole body goes like a flop, and the sudden shock and surprise of changing temperature and falling into a bigger body of water can cause a person to pass out. So vagal tone is very common when people hear news or are surprised suddenly and they pass out. Again, do you go in and start fixing it? No, they don't need to fix it, but you have to make sure that they are able to recover. And if they're not, they are in a cardiac arrest and you need to do the CPR and bring them to the emergency and work that. So don't ignore them, but at the same time, mostly people will come out. Recreational drug use, hypothyroidism. So hyperthyroidism causing tachycardia, hypothyroidism causing bradycardia. Electrolyte imbalances, prolonged bed rest, etc. So let's see this one. Count the number of big boxes. So see here, 1. So this is almost at the boundary, so I'll take that as a boundary. 1, 2, 3, 4, 5, 6, almost 6 boxes. So 300 divided by 6. So this person has about what? 40. 300 divided by 6, about 50-ish. So this person has sinus bradycardia. Why do I say sinus? Look at this. The P wave is present, QRS complex is present, T wave is present. So those clusters of waves are repeating. It's just that they are repeating after a longer duration than normal. Again, this may be normal, this may be an athlete, and they are all set. So I can't judge by looking at it. I can only say that the rhythm is slow. Now, is there a pathology there? I cannot tell from this because the QRS complexes and things are looking normal. Then is the respiratory sinus arrhythmia. As we talked about it, some people call it sinus arrhythmia as well. I would like to call it RSA just to make sure that we are differentiating it. Respiratory rhythm changes are, as I said before, the inspiratory center in the medulla. When we inspire, it causes the nerve impulse to spill into the sympathetic system, and that causes sympathetic discharge, and the heart rate becomes faster. And then same thing on the opposite side, and the heart rate becomes slower. Now, in the EKG, if you're going to call something sinus arrhythmia, you better have some sort of respiratory synchronization with those wave patterns before you say, I have found respiratory sinus arrhythmia. Now, this arrhythmia it is usually normal, right? So I have it, you have it. Normally it is negligible. You don't really find it out, but it can sometimes be pronounced. Even then it is okay. However, the elderly folks, obese folks, folks with diabetes mellitus, patients with diabetes mellitus, and long-standing hypertension may not show the respiratory sinus arrhythmia, and that is because of their situation. Now, what is sinus arrest, asystole, and then escape? It's very simple. As I said, when somebody passes out because of the vagal tone, they should eventually come out. So what happens is, if for some reason SA node stops working, this is called sinus arrest. There is another term called sinus exit block. What that means is that the SA node is actually working, but there may be an injury around it which caused the working SA node's impulse to not come out. So that is the sinus exit. Nerve impulse is trying to exit, is blocked. Sinus exit block and sinus arrest are the same thing. At the end of the day, the SA node is not able to bring its impulse out or is not producing the impulse. So as soon as that happens, it is not necessary that immediately other parts of the heart pick up the responsibility of creating the impulses and go from there. It doesn't happen that way. Other parts are normally dormant and they're just sitting there and waiting for SA node to give them the orders. So if the SA node stops, then those sleeping AV node and other conduction block systems, they open up their eyes after a few seconds and say, what the heck, why are we not getting impulses? Then they decide to start working. So between the time of SA node failure and the resumption of the impulses by other parts of the heart, between that time, the impulses are not going to be present. That time is called asystole. Why asystole? There is no beat during that time. There is no electrical activity. And when another pacemaker in the heart starts working, that is called the escape rhythm. Something else took over and started working. Luckily, fortunately, if the escape rhythm does not occur, then the patient would stay in asystole and die. So this is the important concept. Sinus arrest occurs, asystole occurs, and then escape occurs. So look at this rhythm strip down here, and you would see all these things. Here we have a normal QRS complex. This is another normal QRS complex. But then see here this long pause. Now, how do you say that this is sinus arrest and not some sort of a conduction block? Look, there is no P wave here. That is your way of knowing that this is a sinus arrest. If it was not a sinus arrest, or if it was not a sinus exit block, then the P wave will be present. It's just prolonged, and we'll see some other part of the body or the conduction system having a problem. So there is no P wave. And then there is no P wave here. There is no QRS complex here. And this became a prolonged time. This time is the asystole time. There is no systole here. There is no beat here. So this is asystole. And finally, this is where something else picked up and started working. So again, there is no P wave here. Something else has started to work now. We don't know if it is AV node. We don't know if it is the conduction pathways, or we don't know if it is the ventricular system. We can have a guess by looking at the rhythm. So look at the rhythm here. I'll look at this rhythm. 1, 2, 3, 4, 5. So about 5. So 300 divided by 5 is about 60-ish. To me, this looks like a junctional rhythm. This looks like AV node doing the function, because AV node can produce up to 60 beats per minute. But ventricles cannot do that. So SA node, the fastest, second fastest AV node, then ventricles. So if it was ventricles that had picked up the work, then there are more characteristic problems in the EKG that we could see. For example, we could see a reverse P wave, but here this is a junctional arrhythmia. So here, non-sinus pacemaker. So please remember this. This is going to help you identify the EKG's arrhythmias. The AV node can produce 40 to 60 beats per minute. So just like I did in the last strip, I saw that the beats per minute were 60. I said, all right, this seems to be an AV node. Ventricular pacemaker will have the beats about 30 to 45 beats per minute. Really difficult for patient to live with that. So you'll have to provide some sort of a help. And then there is another thing, and that is reverse P wave. If, for example, let's say that AV node is here and the SA node is here, and normally current goes from SA node towards AV node, and P wave is upward, let's say in lead 2. Now if the current is coming from AV node backwards, the lead 2 would show an inverse P wave. So whenever you see an inverse P wave, you should be assured that there is some other part of the heart that is doing the pacemaker activity. So this is the lecture for today. We will continue with the junctional rhythms and then the ventricular arrhythmias in our next lectures. Of course, we'll talk about fibrillations and flutters and reentrants again on the EKGs, not the pathophysiology. I've done them before. If you wanted to get the recording of this lecture, we will have it present with notes on our site at drbeen.com as well. Thank you very much for your time.